So, my topic is about the anterior segment OCT. I'll be dealing more with because we have the swept source OCT in our department. So, our discussion will be more about swept source OCT, case-based discussion. And as we all know that ASOCT helps us in obtaining like an optical biopsy, or maybe like in terms of the systemic thing, we can say like the CT scan of the cornea and the ocular surface, and it helps us in imaging various degenerations or pathologies of the cornea. And it's based on the principle of low or coherence interferometry and relies on the backscattering of light as it travels to media. So we have like the three main categories of the OCTs, like the time domain OCT, which is not that much into vogue right now. And then we have spectral domain OCT, or also known as Fourier domain OCT. And then the latest ones which we have is the swept source OCT. Compared to the posterior segment OCT, the wavelength is longer because we want a better resolution for the anterior segment structures. Just for the residence, just how a normal AS OCT looks like. The tear film is the first anterior most layer, which is hyperreflective layer. Just behind that, you have the corneal epithelium, which is relatively hyporeflective, and the stroma is like variable reflectivity, hypo to hyper, you can say, but not very hyper or not very hypo. Then the endothelium again appears hyperreflective. Coming to the conjunctiva, we have the hyporeflective conjunctival epithelium. Of course, the anterior part would always be the tear film, which is going to be hyperreflective. Then the subepithelial conjunctiva is hyperreflective, and then the substantia propria and the also appears little hyper to hyporeflective. Then the scleral band is again hyperreflective in appearance. So the swept source OCT compared to other OCTs gives us both longitudinal as well as the axial scans. So it gives you a 360-degree view. Along with that, it gives you a 3D image of the ocular surface, and you can even visualize the angles by going for the 3D view. And it has a very high scanning speed, and you can image the cornea in less than 2.5 seconds. So it gives you these various parameters, not going to the details of it. Along with that, it also gives you topography of the eye, and epithelial mapping also is another feature in it. So the most common etiology that an anterior segment surgeon uses OCT is to look for OSSN, just for diagnosis, at the same time for management and following up the cases. So here we can see this patient who has got this lesion on the limbus and involving this the conjunctival region also. Here you can see this image is not of very high quality. You can see this hyperreflective mass lesion, but you can also see that below that you can see a clear plane, that is the cleavage plane. On doing a biopsy, we could see those keratin pearls and increased mitotic figure suggestive of OSSN. So another feature, like here in this picture also, you can see in OSSN typically you see increased hyperreflectivity of the epithelium, thickened epithelium, and there is abrupt transition between the hyperreflective epithelium to that of the hyporeflective epithelium of the cornea. So that's very important from our diagnosis point of view to diagnose OSSN. Another mass lesion that we usually that we may come across is a pigmentary mass lesion. As we all know that for all pigmentary lesions, UBM is a better diagnostic tool compared to that for ASOCT because of the backshadowing. But here in this image, you can see on OCT there is this homogeneous mass compared to that of the OSSN that we saw was more hyperreflective. This is relatively more hyperreflective. And but this homogeneous mass does not have any cystic spaces. Like in this image, you can see there are cystic spaces present. Like that is a case of a nevus. And on doing a biopsy and immunohistochemistry staining, we could diagnose this case as conjunctival melanoma. Another case that we all use OCT for is, first of all, to look at the depth of the lesion in case of keratitis and ulcerations. In this image, we can see this corneal abscess, we can see a hypopyon, and along with that, you can see a lenticular abscess. So the depth of swept source OCT is so good, you can actually go into the details and image slightly posterior structures as well. This one we had published in ophthalmology. Another feature that our glaucoma colleagues use the swept source OCT and OCT in journal is to look at the trap morphology and how the trap is behaving. But in other features also, like in this interesting case, who presented with a spontaneous filtering bleps in the conjunctiva. So you can see that the conjunctiva in the sclera lesion is also very beautifully imaged, and you can actually see the fistula here. So the depth of penetration is also good, so you can visualize even subscleral structures or maybe like lamellar scleral structures beautifully well. And such kind of features you can see in Trabulsi syndrome as well. Another condition here, this was a lady who was a known case of multiple myeloma, and she had this multiple lesions here with subcutaneous bleeds, and then she presented to us with watering, and when we saw she had got this granular yellowish mass lesions in the subconjunctival area. On doing an OCT, we could see this hyperreflective linear opacities, along with that this hyperreflective nodular mass at the base, that's the base of the substantia propria. And on doing a biopsy of the conjunctiva, we could see that also we did a confocal microscopy. We could see this hypocellular lesions, blob-like lesions just adjacent to the vessels. This is a vessel, and on doing a further biopsy, we could see that it was a case of conjunctival biopsy with apple green birefringence. This case we have reported because the ASOCT can give us an idea about the diagnosis, at the same time preemptively letting us know, even before doing a biopsy, that the patient could be having amyloidosis. Another case here, we know that we use OCT to look at the cornea along with the thickness, along with we look at the demarcation line after doing a C3R. And keratoectatic disorders, it has a big role to play. This was a lady who had decreased vision in both eyes since childhood, and one eye was lost because of some trauma in the past, and the other eye also, where here we can see in the right eye there are some opacities in the cornea. On doing an OCT, you can see there is diffuse thinning of the cornea from periphery to the center. Along with that, she has a very deep anterior chamber. Because she had this bluish discoloration, not very well visible in this picture. Along with that, systemically, she had arachnodactyly, along with joint laxity, and slightly dolichocephaly also. So we further evaluated this patient, and she turned out to have a biallelic mutation in ZNF469 gene, which is responsible for brittle cornea syndrome. And this we had reported. So you must look for other features also once you see on imaging. Of course, pentacam also had thinning. And as keratorefractive surgeons, we use our OCTs for ICL and IPCL planning. And the Swepsos OCT also provides a K's formula, NK formula, which gives you an idea as to how much of the size of ICL that you can aim for in order to get a good vault. So it helps in better predictability of the vault. This is a case of a 26-year-old male. He had undergone ICL and vision was good, but here we can see that the vault is quite high. It was almost around 960 microns. So this patient we took up, because it was non-toric ICL, we took up for ICL dialing. As we know, this video is not playing. So we dialed the ICL in the vertical configuration, because ICL is usually in the horizontal configuration, and we all should know that the sulcus is vertically oval. So when you have a vertically oval sulcus, you can get some amount of flattening of the vault by just rotating it in vertical configuration, as long as it's not a toric ICL. Other than that, in refractive surgery procedures, we can use the OCT to look at the flap. And some patients who may present to you with post-smile or post-LASIK blurring of vision, you could look for, very carefully look for, if especially in increased intraocular pressure, look for any fluid pockets like pressure-induced stromal keratitis, PISC. So this patient had the fluid pocket and had raised pressures, and after stopping steroids and controlling the IOP, we can see the fluid pocket has disappeared. And along with that, now in our department, we are routinely using Swepsos OCT because it takes around less than 2.5 seconds to image, and it requires only incidental fixation and not prolonged fixation. We use it routinely to image babies, and we have a departmental publication of our Swepsos OCT in children with congenital cataracts, and various morphologies have been described. Along with that, we have recently published our study on the Swepsos OCT compared to that of the UBM in small children. And various congenital corneal opacities were imaged, and we found that it has got very good repeatability along with the reproducibility compared to that of UBM. Of course, UBM is the gold standard in visualizing any opaque structure. Quickly, I'll try to wrap up. And along with that, metabolic corneal disorders, you have this case of mucopolysaccharidosis type 1. Here you can see the patient has cloudy cornea. You may miss. Yes, I'll just quickly finish it, sir. We can mistake it to that of CHED, and you can see the crowding of the cornea and thickened corneas. Another case where only the anterior structures were involved, that the anterior hyperreflectivity was seen. And after doing a biopsy, we could find that there was increased thickness of the epithelium, and the basement membrane complex turned out to be mucolipidosis type 4. So I'll conclude by saying this Webster's OCT is very versatile, non-invasive in vivo imaging technique, which achieves better penetration and visualization of the structures, and it should be more applied to the pediatric corneal diseases as well. Thank you so much once again.